for this webinar. It's always wonderful to see all the diverse audience gathered here. It is with great pleasure and zeal that I, Dr. Pallavi Chaugule, Associate Professor and HOD, Department of Rog Nidan Vikruti Vigyan, Manjushri Ayurved College, Gandhinagar, currently working as Joint Secretary of Rog Nidan Vikruti Vigyan PG Association, welcome you all to our 29th webinar on spine disorders, X-ray diagnosis. The human spine, with its intricate network of bones, discs, and nerves, is a complex structure essential for supporting our body and facilitating movement. However, it is susceptible to a range of conditions. Various disorders can affect its health and function, leading to pain, discomfort, and impaired mobility that can significantly impact quality of life. Radiological imaging plays a crucial role in diagnosing these conditions, providing valuable insights into the spine's structure and abnormalities present. It's our privilege to have renowned consulting radiologist, Dr. Amita Thakre Madam, as our today's esteemed guest speaker. We are also privileged to have Dr. Shalini Rai Madam, Associate Professor, All India Institute of Ayurveda, New Delhi, to be our chairperson. Madam has more than 13 years of teaching and research experience. She has authored 2 books, has contributed more than 10 chapters in other books, and has credit of publishing various national and international papers. But before we dwell into the intricacies of spine disorders, exploring common conditions such as degenerative diseases, spinal stenosis, herniated discs, etc., I would request Dr. Snehal Rane Madam, Assistant Professor, Siddhakala Ayurved College, Sangamner, to introduce our association to the audience. Over to you, ma'am.
Thank you so much, ma'am. Am I audible?
Yes, you are audible loud and clear.
I would like to tell about us, RVPGA, that is Rog Nidan Vikruti Vigyan PG Association. That means our organization RVPGA was formed in the year of 2016 under the able and dynamic leadership of Dr. Subhash Wage sir, with the aim to give the legal and status pathologist and radiologist to the PGs of Rog Nidan. Our organization is duly registered under the Society Act of 1860 at Charity Commissioner Office, Nagpur. Post-graduation student teachers of Rog Nidan and Vikruti Vigyan Chaya Vikran Vigyan can become our members. Our is the only organization which is fighting for the lawful rights of Rog Nidan and Vikruti Vigyan PGs. Even the NCISM had also directed State of Maharashtra to consider RVPGA as a stakeholder in the Constitute of Pathology Regulatory Body of the state. RVPGA is pursuing in the matter with the state and central government. Not only this, RVPGA is constantly pursuing the implementation of NCISM salary structure in all the private Ayurvedic colleges across the nation. All the communications and details are uploaded in our website, that is www.rvpganagpur.com. Please visit that website. I would like to tell about our activities. Regular conduction of online webinars and offline seminars, both on national and international platform. So far now, we conducted 29 national webinars on different diagnostic topics and national conference on X-ray and diagnosis at Nagpur. This is our 30 webinar today's. Hence, our training program for PG at our partner NABL accredited pathology laboratory at Mumbai, Nagpur and Pune. We have planned a microbiological hands on a training program for our PGs and 9th March on date 9th March 2024 at Nagpur. Publication of research papers of Nidan student and facilities in our international journal Diagnostic and Research, that is IJDR. Interested can visit the journal website www.ijdrindia.com. Our journal is enlisted in 8 databases. 2 issues have been published. We are publishing books chapters through our edited book volume series, which is an international publication called RIPI, and it is duly registered in Government of India's ISBN portal. Those who want to contribute book chapters can visit RIPI. That is website is www.rvpgaiipa.com. We had published All India Rog Nidan PG. This thesis, All India PG Rog Nidan PG thesis book, consisting in all Rog Nidan PG's titles from 1985 to 2023, for the easy references of our PG and faculties. This year, we have started 2 courses. That is DAPT, that means Diploma in Ayurveda Pathology Training, and DXDT, that means Diploma in X-ray Diagnosis and Techniques. Both the courses are affiliated to the reputed RAST, Nagpur University. We request aspirants to take the benefit of it. We are giving the legal fight for the issues of Rog Nidan and Vikruti Vigyan PGs at appropriate forum. So we have our YouTube channels, Facebook page, where you can see the educational activities past also live. So I would like to thanks Dr. Pallavi ma'am and Dr. Wage sir, and would like to invite all PGs of Rog Nidan and all faculty members. Please visit our website, that is www.rvpga.associate.com. Thank you, ma'am.
Thank you very much, ma'am, for the introduction. We all are aware that spine disorders are the major portion of our OPDs and IPDs. So it is very essential that we understand the delicacies and intricacies of the matter. Today, we are privileged to have Dr. Amita Thakre ma'am, who will guide us through the radiological imaging. I would like to introduce ma'am before we start into the actual session. Dr. Amita Thakre ma'am has completed her MBBS from MGM Sevagram, Wardha. She further pursued her MD in radiology from the same college. She has worked in Government Medical College, Nagpur. She has also experienced in Central Institute of Medical Science and Hospital, Bajaj Nagar. Madam is currently working as a consultant radiologist and director at Noble Diagnostics and Imaging, Nagpur. Madam has presented various papers in national and international journals. Madam has done her PG with the thesis topic MRI evaluation of lumbar spine. She has special interest in women's imaging and fetal medicine. Madam, I am sure your expertise and vast experience in radiology will inculcate new vision and insights in our audience. Requesting you to start your talk, ma'am.
Thank you very much. Good morning, everyone. Am I audible?
Yes, ma'am.
Yes, ma'am. You're audible, ma'am.
So, good morning, everyone. I am very much thankful to the Rog Nidan Vikruti Nidan PG Association for giving me this opportunity to present on the topic of spine. And I also specially thanks Dr. Subhash Wage sir, because he is fulfilling my desire of teaching. I always like to teach, but somehow in corporate practice it's not possible. But through this channel, I am getting that opportunity to teach. So today I am presenting on diagnostic interpretation of radiograph of spine. Previously, I have presented the same topic with addition of skull in the national conference in the month of November. Now I am focusing more on spine and I will go a little bit detail. So let's start with the topic. Now spine, you know the Marathi poem Kana. So जोपर्यंत कणा ताठ आहे माणूस उभा आहे, so that is the same thing with the spine. Just a minute. So now these are the various modalities which are used for the evaluation of spine. We have radiograph, we have CT, and we have MRI. Now in a radiograph, basically we mainly evaluate the skeletal structure or the bones. In CT, there is excellent visualization of the bones as well as we can visualize the soft tissue structure. However, MRI is more preferred to see for any early changes in the marrow of the spine as well as for evaluation of the soft tissue like ligament, like spinal cord and nerve root. Now coming to the spine. Now the basic anatomy I will cover in short. So this is cervical spine, this is thoracic spine, this is lumbar spine, a sacrum and coccyx. There are 7 cervical segment, then 12 thoracic segment and 5 lumbar segment. A short view of how the radiograph is taken. Now this is the pictorial depiction of the positioning for the cervical radiograph. Now we are keeping the patient in front of the cassette and we are centering here in the cervical spine region to take the cervical spine AP view, that is anteroposterior view. Now this is the position for taking the lateral view. Here also we can see the centering is done in the region of cervical spine. Now this is the oblique view. In oblique view, we tilt the patient's neck by 45 degrees and we obtain an oblique view. Now the oblique view is taken for better visualization of neural foramina. Similarly, in thoracic spine and lumbar spine also, we take the similar position, only the centering will be in the thoracic spine and lumbar spine respectively. Now, these are some maneuvers. This is the flexion and extension technique. Now, these techniques are used in cervical spine to see for the atlantoaxial instability. So now in this radiograph, here is the extension. This is the dentate space, that is the between the anterior arch of atlas and the dens, it is maintained. However, here we can see there is some anterolisthesis of the arch of atlas and also there is increase in the dentate space size. So it is indicating atlantoaxial instability. Now this is the overview of my lecture. The anatomy, we have covered the anatomical segment now. But here I will be covering the anatomy on radiograph. And the 2 basic views will be evaluated, that is the anteroposterior view, lateral view. And these are the few of the etiologies which we will be talking: trauma, degenerative, neoplastic, inflammatory, infective, and some congenital conditions. So coming to the approach for a cervical spine. I will first cover cervical spine, then thoracic, and then the lumbar spine. So in cervical spine, whenever we get a normal cervical spine X-ray, it doesn't mean that there is no injury. Clinical considerations are particularly important whenever we assess the cervical spine X-ray or the skull X-rays. We should look at the all views which are available in a systematic manner. Now, what is the systematic manner? I have myself do an acronym, that is SAPS. That's CBSC we can say. Just a minute, my battery is running low. Yeah, sorry for the interruption. So whenever we are evaluating a cervical spine, we should see, is the coverage adequate? The alignment, the anterior line, posterior line, and the spinolaminar line. How are the bones? Are their cortical outline, vertebral body height are maintained? And also the spacing of the disc, spacing of the spinous processes. And also we should evaluate the soft tissue, prevertebral soft tissue, paravertebral soft tissue, posterior vertebral soft tissue, and we should look at all the age of So now coming to the cervical spine X-ray. Now this is the which way? This is the lateral view. So on lateral view, first we are going to see is the coverage adequate. Now the cervical spine should have the coverage from the base of the skull to up to T1 vertebra. Now yes, C2, C3, C4, C5, C6, C7 and T1. So T1 vertebra should be included, or the cervicothoracic junction should be included. Then coverage is done, then we look for the alignment. Now for the alignment, we have three lines. The green one is the anterior line, which joins the anterior margin of the vertebra. Middle one is the posterior line, orange one. The posterior line, it joins the posterior margin of the all vertebral bodies. And then comes the spinolaminar line. Now the spinolaminar line is affixed by the joining of the anterior margin of the spinous process, and it actually joins the skull base superiorly. So here we can see the anterior line, a posterior line, and the spinolaminar line. Now this is the what we can say. We have covered the coverage, the alignment. Okay, then look for the bones. How are the bones? Are the vertebral body heights maintained? Yes, they are maintained. How are the cortical margins? There is no disruption. Then we look for the soft tissue. The prevertebral soft tissue here we have to look for, as well as other soft tissue which is available here. And also we should look for the every edge of the margin. Whenever we are evaluating radiograph, don't get satisfied early by seeing one or the another finding. We should further see the entire and further evaluate the entire radiograph. Now here, see, this is the X-ray. Now the lines are maintained. Okay, but how is the coverage? We are seeing that only C6 up to C6 the coverage is maintained. So whenever we encounter such patient, we take a swimmer view. The swimmer view is the lateral view with the arms pulled downward. Now we can see a C7 vertebra and T1 vertebra. Now you see that we can see there is a fracture which is seen in C6 and C7 vertebra. The facet joint which was not visualized here, now it is visualized here. So that's the importance of full coverage of the cervical spine. So this I have covered. We should see the coverage from base of the skull up to the top of T2. Even T1 is considered adequate. If T1 is not visualized, then we can repeat the imaging with the patient's shoulder lowered, that is a swimmer's view. Now we have also seen the alignment and the bones. Now coming to the soft tissue. In soft tissue, we see for the disc spaces. The disc spaces is the area between two vertebral bodies. Is the height maintained? That is, we have to see. Further, we have to see the prevertebral soft tissue. Now the prevertebral soft tissue, it is narrowed until the C4 vertebra. At C4 vertebra, it is approximately less than the 1/3 vertebral body, and below C4 it is usually has the width which is equal to the width of the vertebra, because here we have cricopharynx, we have thoracic esophagus. So the I think, sir, someone is writing on the screen that is visible. Okay, so now we have the prevertebral soft tissue now. Okay. Coming to the, now this is a zoomed out view. This is the zoomed out view of the cervical spine. Now here we can clearly visualize that this is the dens or the odontoid peg. See here. This line, we can see a round here, that is the round corticated margin. Now this is the corticated ring of C2. Why is this ring important? Because in fracture, this ring is discontinuous or disrupted. Here we see the spinous processes, and also this is the anterior arch of atlas. Coming to the AP view. Similarly, in AP view, first see for the coverage. It should cover entire cervical spine as well as upper thoracic spine. Then we should look for the alignment. How is the alignment? So in AP view, we join the lateral borders of the cervical spine as well as shine the spinous process of the cervical spine. If all these three lines are joined, then the alignment is maintained. Also, some of the fractures, they can be seen on this view, although they are less visible. Also, we can see for the spacing, the disc spaces. We should see for the soft tissue now. Here, if there is surgical emphysema, if there is injury to the ribs and the pneumothorax is happening, that can be seen here in the apical region. So we should evaluate every edge of the X-ray. Another thing, we can see a surgical emphysema. Another view that is taken in cervical spine is the open mouth view of the odontoid. Now this is the odontoid process. Okay, these are the lateral masses of atlas. This is the distance between the odontoid peak and the lateral masses of atlas. It should be equal, fairly equal. Sometimes if the patient is rotating neck, it can be unequal then, but it should be fairly equal. So what is the importance? The importance is that in case of a Jefferson's fracture, that is the atlas arch fracture, this distance is increased. And also we should also see for the symmetry here and the apposition here. This is the normal alignment. Whenever one thing is that whenever we know the normal, then only we can find the abnormal. So you should, these images, you should just imprint in your brain that these images are normal. This will help you to diagnose the abnormality very nicely. Now coming to the thoracic, once again, we are just repeating or just revising whatever we have been taught. Now, first of all, you will see the coverage. Now, coverage is C2, C3, C4, C5, C6, C7, and T1. So, the coverage is adequate. The alignment is good. All three lines are maintained. The vertebral body height and the corticated margins, they are maintained. The prevertebral soft tissue is maintained as well. Now, at this C5 vertebral level, it is the width of the prevertebral tissue is more. It is because of the esophagus and cricopharyngeal line, but sometimes it is falsely seen in the young children which are less than 2 years because they can physiologically widen whenever they are crying. Also, we should see for the spaces in between the spinous process. If they are widened, it indicates the ligamentous disruption. Coming to the thoracolumbar spine, the same principle. Use a systematic approach. We have to see for the coverage, alignment, bone spacing, soft tissue, and every edge of the images. And whenever we suspect an instability, we should further image it with CT and MRI. So coming to the thoracic spine, now we see the normal alignment. We take here two lines, the anterior line and the posterior line, which is made out by joining the anterior margin of the vertebra and the posterior margin of the vertebra respectively. We should evaluate for the disc spaces. We can also evaluate the ribs here, so any associated rib fracture is diagnosed. Further, we have the prevertebral and paravertebral soft tissue evaluation here. And also we notice that as we go down in the thoracic spine from D1 to T12, we notice that the width and the height of the body, height of the vertebral body is gradually increasing, and also the spacing of the disc space is gradually increasing. This is a zoomed out zoom view of the lateral view of the dorsal spine. These are the vertebral bodies. These are the disc spaces. Here also we can see the posterior joint, that is the posterior part, spinous process, pedicle, and this is the neural foramina. These are the hilar structure. So if we encounter a sclerotic or lytic mass in the thoracic spine, and we also see there is a mass at the hilum, we can safely say that that is the neoplastic mass at the hilum. It could be a lung mass, it could be a mediastinal mass, it could be a hilar lymphadenopathy with further metastasis in the cervical spine. Hence, the inspecting every edge of the image of any X-ray is at most important. Coming to the zoom view of the AP view of the thoracic spine, here we can see these are pedicles. Now this is called as owl's eyes. You know owl, it has two big eyes, so these pedicles, they resemble owl's eyes. Now why is this owl's eyes important? Sometimes we can see only one pedicle, not another. The another pedicle, it can be destroyed by a metastasis or any lesion. So in that case, we can safely say if the two pedicles are not visible, that is only one pedicle is visible, that is called as winking owl sign. So the another pedicle is either destroyed by any infective or neoplastic or a metastatic etiology. This is the rib, and these are the costo-transverse process joint or a costo-vertebral joint. In lumbar spine, so we see for coverage, at least from T12 up to the sacrum, we are seeing the alignment, the disc spaces. These are the neural foramina. Coming to the further detailed view, this is the facet joint. This is the inferior articular process. This is a superior articular process. Between two, these is the facet joint. This is a spinous process, and this is the P is the pedicle region, and this is the pars interarticularis. Why it is called as pars interarticularis? Because it is seen between the two joints. And one more thing, if there is defect in this region, then it will lead to the ankylolisthesis or retrolisthesis of the vertebra. On AP view, now these are the pedicles, these are the spinous processes, and these are the transverse processes. On this X-ray, we can also see the sacroiliac joint as well as we can see the lower ribs. These are the psoas muscle shadows. These are the psoas muscle shadow. So in case of any pot spine or the mass, now this psoas muscle shadow will be increased. Now coming to the three-column theory of the lumbar spine. Now previously Dennis has said that we can classify the lumbar spine into three columns. Now the anterior column is involving anterior longitudinal ligament, anterior annulus, and anterior two-thirds of the vertebral body. The middle column is involving posterior one-third of vertebral body, posterior annulus, and posterior longitudinal ligament. The posterior column, now the posterior column is involving the posterior elements. These are the facet joints, spinous processes, transverse processes, pedicles, posterior ligaments, that is the interspinous ligament, this is the supraspinous ligament. Now why this classification? Because Dennis has said that if any fracture, if it is involving more than two segments, then we can label it as an unstable fracture. So it may need a surgical intervention. This is a detailed view of posterior ligamentous complex. This is very well visualized on the MRI. So now here we have the ligamentum flavum. This is the facetal joint and facet joint capsule, interspinous ligament, and this is the supraspinous ligament. So these three columns were in the cervical spine. Now similarly, the column are in the lumbar spine also. The anterior longitudinal ligament, along that we have the anterior margin and the anterior line, green one, which is called as anterior column. Then is the middle column, and then is the posterior column. Now further, as I have already explained about the Dennis three-column classification of the lumbar spine, there are different classifications. Now why the rest of the two classifications are there? The Dennis classification, it is having a very false positive value. If sometimes there is a wedge compression fracture which is involving whole of the vertebral body, but it can be a stable fracture, it is not unstable. So it is there is over reporting of the unstable fracture. So now the another AO classification also has come, but we don't use also the AO classification because it is complex and there is inter-reader variability. So now we have agreed upon, or we uniformly follow the TLICS classification, that is thoracolumbar injury classification and severity scaling. Now there are three main components in the TLICS classification. First is the morphology of the fracture, posterior ligamentous complex integrity, and the neurological status. In morphology, we can have compression fracture, burst fracture, translation rotation fracture or a distraction fracture. Integrity of posterior ligamentous complex, that is done on the MRI, and neurological status is by the physical examination, as well as we can also evaluate it on MRI. And based upon this score, now we take, is there a need for surgery or this choice is non-surgical intervention. Coming to the fracture morphology, the compression fracture. Now the compression fracture is simply a compression of vertebral body. You will see it as there is a reduction in the vertebral height and a V-shaped deformity. Burst fracture is the compression with the retropulsion of the superior posterior body fragment. Now translation rotational fracture is because of they are rotating or shearing forces. So there is an anterior or lateral displacement and a facet joint displacement. Distraction fracture is the horizontal fracture of the posterior element, and there is separation of the posterior elements. So coming to the coming to the 3-column model. Now in 3-column model, what we now follow is that if the injuries 1 or 2, they affect any one column only, either anterior or posterior, they are considered stable. If the injuries 3 and 4, now these are unstable fracture because they are involving more than two columns or more than that. Now coming to here, we can say that this is a fairly stable fracture. It may not need a surgical intervention. However, if you follow the Dennis criteria, it will be labeled as unstable fracture. But by TLICS classification here, we can see that this fracture may not need a surgical intervention. In this radiograph, only the posterior column is involved. Here, only the anterior column is involved. Although here 2 columns are involved, but the injury appears fairly stable. Here all 3 columns are involved and hence the injury is unstable. The unstable fracture, they need or might need immediate surgical intervention, that is the take-home point. Coming to the compression fracture now. So compression fracture, what causes in compression fracture is the wedge compression of the vertebra. So you can see that there is now reduction in vertebral height or the wedging in the vertebral height. A cortical break is seen usually in the superior and anterior wall. On X-ray, we can see a horizontal sclerotic band of the trabecular impaction. Usually, the superior end plate is involved. Very less frequently, an inferior end plate is involved, and the posterior cortex of the body, it is intact. Now, why this is important? This is the difference between a wedge compression fracture and a burst fracture. In burst fracture, this posterior cortex of the body is not intact. This is the example now. So, as in previous slide, what we can see here is there is decrease in the vertebral height. There is a fracture involving the anterior wall as well as the superior end plate of the vertebra. This is the superior end plate, this is the inferior end plate. Also, we can see a horizontal sclerotic band, which is because of the trabecular impaction. However, the fracture looks fairly stable. It is mostly involving the anterior column. This is a very, sometimes we can miss the fractures on X-ray. In that case, we can take help of the CT. But if you clearly see here that seeing this anterior line and this anterior line, we can see that this cortical line is disrupted here. And also the superior end plate appears disrupted here. So this anterosuperior quadrant of the vertebral body is involved. So this is a very subtle wedge compression fracture only. On CT now, see the anterior margin of the rest of the vertebra and here the anterior margin, this cortex is disrupted. And if we see the thinned out section, here this is the fracture line. It is involving the anterolateral wall and further going posteriorly. However, the posterior wall is intact. So that's the, and we can see the section here, the section is 2.5 millimeter. Here there are thin sections of 0.9 millimeter. So whenever we see for the bones, we always go for the thin sections to diagnose some subtle fractures which are missed on thick slices. Another example, now this fracture was not that much visible on X-ray. A CT and MRI was further done. Now we can see a break in the anterior wall and the superior end plate. Similarly, here there is break in the anterior wall and superior end plate, and on MRI we can see clear cut the corner fracture and reduction in vertebral height. However, the ligamentous complex, it appears intact. Also, there is no disc injury. This is the MRI image. So I'm just elaborating MRI anatomy here. These are the vertebra and this is the disc space. This is the thecal sac and this is this spinal cord. Coming to another one column fracture, that is the spinous process fracture. This fracture is also fairly stable, no need for a surgical intervention. Coming to burst fracture. Now, as we have already seen, the burst fracture, it involves the retropulsion of the postero-superior vertebral body fragment. In waist compression, the posterior cortex was intact. Here, the posterior cortex is not intact. There is retropulsion. Okay. Now, we can also see that there is a sagittal fracture of the vertebral body. Here, the posterior elements, they can be involved. And also, another finding is the widening of the interpedicular distance. Now, let's see it on radiograph. As compared to these vertebra, first of all, we will see for the alignment. Now, the alignment is lost. The green line and the orange line, they are broken. Coming to the vertebral body height, it is reduced. As well as we can see that it is posteriorly retropulsed. So, disrupted anterior middle column, loss in vertebral height, and there is retropulsion. Now, whenever there is retropulsion of the fracture fragment into the spinal canal, it can lead to high risk of spinal cord or a nerve root damage. And these fractures, they should be further evaluated with the MRI. Coming to the CT imaging, here it can be seen clearly that there is reduction in the vertebral height. There is retropulsion of the fracture fragment into the spinal canal. On axial images, it is seen here. So it is causing a spinal canal stenosis as well as injury to the spinal cord. The lamina here, they are also broken. So a posterior element can be involved in the burst fracture. On AP view now, we have seen the winking owl sign. Now what is happening here? These are the two eyes of the owl. Winking owl means only owl sign. These are the two eyes of the owl. They are spaced normally, but here they are seen distant. So there is distance between the interpedicular line. So sometimes whenever there is only anteroposterior radiograph, what we can see is the distance between interpedicular, both the pedicles is increased. That can indirectly indicate that there is some fracture. Also, we can see that the vertebral body height as compared to superior and inferior vertebra is reduced. Coming to another fracture, that is a translation rotation fracture. It is causing because of the rotational or a shearing force. So in this fracture, what happens is that there is anterior as well or a lateral displacement. The facet joints, they are disrupted or dislocated. It can be accompanied by a rib or transverse process fracture. And in this case, if the posterior ligamentous complex is injured and also there is neurological deficit, then we have to take the patient for immediate surgery. Now, this type of fracture, they should be evaluated with the MRI. Now, here we can see that there is a fracture, reduction in vertebral body, posterior cortex is involved, there is retropulsion. One might say that, oh, this can be a burst fracture. But when we evaluate it on the transverse image, we can see that the facet joints, they are disrupted. There is focal kyphosis here. Transverse process, they are involved. Facet joint, they are involved, and also there is rib fracture. So this is a translation rotation fracture, not a burst fracture. And also another one point is that here, this you can see it here, there is thin strip, but here it is increased in thickness. So it is accompanied by a paravertebral hematoma. Coming to the distraction fracture. Now, distraction fracture is the most severe fracture. It usually, in 99% cases, needs the surgical intervention. So what happens is here is that there are This is characterized by the horizontal fracture of the posterior element. So posterior elements are also fractured, the vertebral elements are also fractured, and the posterior elements, they are separated. Here we can see alignment, and the anterior line and the middle line, they are disrupted. Okay. Reduction in vertebral body height, and we can see a widened interspinous distance and a fracture line which is passing through the posterior elements into the vertebral body. Here we have demonstrated it very nicely. Distance increased, a fracture line straight going from posterior elements into the vertebral body. Now these are the injuries which are highly unstable. They carry a high risk of neurological deficit and abdominal organ injury. These cases should be further evaluated by MRI, and they need a surgical intervention. Coming to the cervical spine trauma, the cervical spine trauma have many fractures. There are many fractures which go by name also. So coming here, first of all, we are seeing for the alignment. Now this alignment is lost. We can see a fracture here. So this is extension teardrop fracture. Another thing, alignment lost, anterior as well as posterior. This is the flexion kind of teardrop fracture. The facet joint here, we can see they have a normal spacing. The facet joint at this level is widened. There is also loss of alignment. So by assessing only the alignment, we can say that there is some fracture which is involving anterior as well as the posterior element. Fairly stable fracture of the spinous process. It is involving the C7 spinous process, which is famously known as the Clay-Chauvel's fracture. Prevertebral soft tissue thickening is an indirect evidence of cervical spine injury. In this radiograph now, we can see that there is no obvious fracture. The alignment appears better. Somewhat here, the vertebral body height might be reduced. There might be a fracture. But what we can clearly see is that the cervical soft tissue is thickened. At the level of C3, it is thickening, and the width is more than the 50% of the width of the vertebra. So it is an indirect fracture and the only visible sign of injury. Now this case should be further evaluated either by MRI or by CT. Another entity is the bilateral perched facets and the locked facets. So first coming to the perched facet. Now what is meant by perch? Perch means they are sitting on one another. On this X-ray, see for the alignment. The alignment is lost on all three lines. The vertebral body height appears fairly maintained. What is happening here? In this facet joint is coming before the facet joint of the inferior level. See for this is the alignment, normal alignment. Now here the alignment, that this part should come inferior to this, but it is coming superior and it is going facet. They are sitting on each other rather than being in alignment. So these are the perched facet. Now the perched facet, what does it cause? It causes an anterior displacement of the vertebra. So now the vertebra is displaced anteriorly, the facet joint is coming anteriorly. What it causes? It causes the compression of the cervical spinal cord, and it results in the neurological deficit. Another thing here, assess for the prevertebral soft tissue. Don't get satisfied, oh, we have seen the fracture, we have seen all sides. Look also for the soft tissue. Here the soft tissue is thickened, which is due to a prevertebral hematoma. So the derangement of the spinal canal in case of the perched facet, it has a high incidence of spinal cord injury. Now those were the locked facet. The facet was sitting on one another. Now these are the further more severe condition, locked facet joint. This is the normal alignment of facet joint. Now this facet joint, which should be here, it has come anterior to it, and this inferior facet joint is coming posterior to it. So they are locked. Now they can't go back. If the perched facet was there, the perched facet should be sitting here on this point. You can say on the tip or the tip of the mountain of the facet joint, the perched facet is sitting. But here it has crossed that tip and it has come anterior. So this is the locked facet joint, which is seen along with the disruption of all three lines and the anterolisthesis of this vertebra. Now here the spinal canal is compromised. There is spinal cord injury. A definite spinal cord injury is there whenever there are lock facet. That should be further evaluated with the MRI. Now in this patient, they should be transferred immediately to a tertiary care center, and that too the cervical spine should be kept immobilized to avoid further damage. Another special fracture is the hangman's fracture. Hangman's fracture is the spondylolisthesis, that is the break in the pars interarticularis region of the second cervical vertebra, that is the axis vertebra. Now there are for many many types of the hangman's fracture. The type 3 is the most severe one, which occurs whenever we are hanging a culprit or a culprit patient. It causes sudden compression of the cervical spinal cord and cervicomedullary junction, which leads to the compression over the respiratory center and a sudden death. However, the type 1, there are simple fractures. There is no as such compression of the cervical spinal cord. It is the simple most fracture. Neurological involvement is rare whenever they are causing by the traffic accidents. The alignment is lost in the anterior line as well as in the posterior line. Jefferson fracture, I have mentioned that they are the fractures of the either the anterior arch or the posterior arch, or anterior and posterior arch of the atlas. Coming to the peg view, open with peg view of the radiograph, as we have discussed, now this alignment is lost. They should be in this line. The alignment is lost. The distance between the peg and the lateral masses of C1, it has increased. So it indicates a Jefferson's fracture. We have seen that a corticated ring of C2, this superior margin of the corticated ring is now disrupted. So it is causing the peg fracture. This is the nexus criteria. The nexus criteria is a National Emergency X-ray Radiography Utilization Study. It says that if the patient is having no tenderness, no neurological deficit, he or she is alert, no intoxication, and no distracting painful injury, then it is very rare or unlikely the patient is having a cervical spinal injury. So a cervical spinal injury is very unlikely if the patient has no neck pain or tenderness. Now in this X-ray, what we see, okay, the coverage is good, the alignment is good, oh, the patient is wearing nice earring, but these findings should not distract us. The prevertebral soft tissue is good, everything is fine, few anterior osteophytes are there, but we should see to the every age. Now coming to the every age, we can see that the C2 spinous process is injured here. This is the fracture, as well as this spinous process is also injured. So we should look carefully on an X-ray. Coming to the transverse process fracture, these are the normal transverse processes. These transverse processes are fractured here. In this case, we should see for the liver or the kidney injury because it can be associated with this. Another common entity is the osteoporotic fracture, which is fairly common in India, especially in elderly patients above 60. See for the, okay, the alignment appears fairly maintained. However, there is a focal kyphotic deformity. The vertebra, the height appears maintained. Here the height is reduced, but the vertebra, they are appearing more of a transparent kind of thing. They are not that white. So the whiteness or the density of the vertebra or bones is coming from the calcium content. Now, whenever the calcium content is less, we can see that the vertebra appears fairly blackish or there is reduction. So this is the osteoporotic fracture. Now the osteoporotic fracture is causing reduction in the vertebral height. There is anterior wedging, and this leads to the focal or increased kyphosis. Another patient of the osteoporotic fracture. Now here the previous morphology was wedging. Here the morphology is the osteoporotic biconcave fracture. Along with that, we can see osteoporotic changes as well as degenerative changes in the spine. Another patient, there is significant reduction in the vertebral height. we can see a wedge fracture with almost paper thinning of the vertebra. The vertebra appears disappearing. This is another severe osteoporotic fracture. So, as we have talked about the trauma now, the second common pathology which we get is the degenerative. In degenerative, we can see for the osteophytes, reduced disc space height, there can be end plate changes and a facetal arthropathy changes. Let's see them on X-ray. Alignment is all good. Bony height appears maintained, but the disc spaces here, they are reduced. Here, these are the anterior osteophytes. Also, we can see these end plates are sclerotic. So, this is a degenerative changes, as well as there is another finding, there is a loss of cervical lordosis, which can be due to a muscle spasm or due to degenerative changes. So, the degenerative changes encountered in this X-ray are reduction in vertebral height, osteophytes, and sclerotic end plate changes. This is the calcified anterior ligament. Sometimes it is also seen in the spondylodegenerative changes of the cervical spine or lumbar or thoracic spine. In lumbar spine now, similar, we have osteophytes, reduction in disc space height, reduction, and there is sclerosis of end plate changes, sclerotic end plate changes. We have discussed that this is the normal alignment. Here the L5 vertebra has migrated anteriorly, that is ankylolisthesis. So it is because of the defect in the pars interarticularis region. There is ankylolisthesis of L5 vertebra. Along with that, there is a sclerotic end plate changes in opposing end plates at L5-S1 disc level with reduction in L5-S1 disc height. Another entity is the atlantoaxial subluxation. Here, we in these cases, we take an extension radiograph as well as flexion radiograph. In extension radiograph, we can see that the atlantoaxial distance is maintained. However, in the flexion radiograph, it has increased. So, it indicates an atlantoaxial subluxation. Another common entity is the spondylar arthropathy. Now, there are various spondylar arthropathies, but they are fairly seen similar on the MRI or X-ray. What we get is a shiny corners. These are the sclerotic changes at the corner, and along with that on MRI we can see there is edema. Sorry. So this is the sclerosis noted, which are also known as the shiny corner sign. The edema which was not visible on radiograph, here we can see the edema. This is the early case of any spondylorthopathy. In severe cases, most common is the ankylosing spondylar arthropathy. We get the calcification or the ossification of anterior longitudinal ligament, posterior longitudinal ligament, along with the fusion of or the ankylosis of the facet joint. Normal facet joint, here the facet joint space is completely obliterated, along with there are flowing syndesmophytes or ossification of anterior longitudinal ligament. Another thing we should look for on the radiograph of lumbar spine on AP view is the widened is the sacroiliac joint. These are the normal sacroiliac joint. However, we can see a sclerosis here, and the joint spaces they are widened. So it is indicative of sacroiliitis. In later aggressive and progressed cases, we get fused sacroiliac joint. So we have now covered a trauma, degenerative and orthopathic changes. Another most common lesions which are noted in spine are not the primary spinal tumors, but they are the metastases. Now the metastases, they can be multifocal, they can be sclerotic, or they can be lytic. Now there are from the different primaries, different type of metastases occur. For example, the prostate ones can have a lytic or a sclerotic metastasis. Here we can see that all alignment is maintained. There are few anterior osteophytes, but coming to the vertebral body, we can see there are more white here. More white here. This is normal, but these are more white here. So these are the sclerotic metastasis. Coming to that owl sign, the two eyes of the owl are seen here, but here the owl is winking. because another pedicle, the left-sided pedicle, is destroyed by the lytic lesion, which is mostly a metastasis. Coming to the port spine, now the port spine changes if they are very much advanced or they are accompanied by the collection, then only it can be diagnosed on radiograph. The early changes of the spondylodiscitis, they are not seen very much clearly on the radiograph, rather it is seen on MRI most commonly. CT will also not diagnose the marrow edema phase of the port spine, it will diagnose the destruction or any collection if there is. So on chest X-ray, we can see that there is widening of the parafractal stripe on both sides. So it is mostly a collection from the port spine. Some congenital variants, here we can see that there is leftward bending of the spinal column. There is a scoliosis to the left. And also we can see there are two curves, major and minor. The major curve is occurring in the thoracic spine. The minor curve is seen in the lumbar spine. It can be idiopathic or there can be etiology. Now the etiology can be a hemivertebra or a block vertebra. Here we can see that there is scoliosis, with this being the major curve. The hemivertebra is here. Hemi means half vertebra. This is the block vertebra. The two vertebrae, they are fused. Another case we can see here is the hemivertebra, which is causing the scoliosis. This is the block vertebra. Now the block vertebra can be complete or partial. This is partial because only the anterior part is fused and there is reduction in vertebral height. In this case, the vertebra, they are completely fused because the posterior elements are also fused and the body are also fused, and there is total obliteration of the disc space. Another common and interesting entity is the rugger jersey spine. Now we know the rugger jersey, they have these stripes, alternating stripes of white and black color. In these renal osteodystrophy cases, we can see sclerotic changes with normal marrow, sclerotic changes. So this is giving an appearance of rugger jersey. This is the rugger jersey spine in case of a renal osteodystrophy. Furthermore, what we can additionally see here is the calcific atherosclerotic changes in aorta. So that is you have to show. We have to see every age of the radiograph. Now I think I have covered almost all the etiology. This time I have in detail covered the traumatic etiology of the spine. So I think we should take some quiz. Baghe sir?
Yes, ma'am. You can, ma'am.
You can. So just how we can see the answer.
Ma'am, it will be in chat box, ma'am. Audience can message in chat.
Okay. I will give you 2 minutes to evaluate.
Requesting all the participants to actively answer the quiz.
Previous one was the passive learning. Now, if you actively write down the findings, it will be the more beneficial to you.
Appears to be fracture here.
In which vertebra? Superior one, inferior one, or a middle one?
Middle one.
Middle.
Now, what kind of fracture it is? Is it a compression fracture or a burst fracture, or we can say distraction kind of fracture, chance fracture?
Burst type appearing.
It is burst, but also we can see that this distance is increased. There is this fracture here. Yeah, so there's a distraction kind of fracture. It is involving vertebral body and a horizontal fracture of the posterior element. It is a horizontal fracture which is extending into the vertebral body. So what we will do next in this patient? We will do an MRI imaging. Okay, we should assess for the neurological deficit, and thus this patient may need a surgical intervention. Okay, now coming to the second one. Is alignment proper?
No.
No. So which lines are disrupted?
I think between C6 to C7. This is
So
this
now
one.
this is the C2, C3, C4 vertebra. This
C5.
anterior, yeah, alignment
C5.
is disrupted. Anterior, posterior, as well as spinolaminar. Okay. Okay. So C2, C3, C4. Now C4 is coming anterior. C5 is going there. What another finding? Does this patient will need an MRI and surgical intervention?
Yes.
Yes. Why?
To overcome the compression.
And more?
For alignment.
Yeah, for alignment, but the surgery is mostly for the salvage of the spinal cord injury.
Yeah.
Look here for the facets. They are almost sitting on one another. So this is a perch facet. So in this case, we should do an MRI, see for the spinal cord managed, and then we can do a surgical intervention for fixing this. Next one.
Again, loss of alignment between
Yes, loss of alignment
4,
is there.
5, between 5 to 6. This.
Yeah. Loss of alignment, all three columns are disrupted. How are the facet joints? This facet is coming anterior to the facet joint below. This is a lock facet. The lock facet. And also we see that this prevertebral fat tissue type, prevertebral tissue is widened. So it is accompanied by a prevertebral hematoma. Lock facet, spinal cord injury has to be there. It should be evaluated by further by MRI, and surgical intervention is needed. This is the simple one. What kind of fracture it is? It appears osteoporotic and a compression fracture. The posterior, yes, compression, very good, compression fracture. The posterior cortex is intact, so we will call it as a compression fracture only. And moreover, it appears, yeah, osteoporotic. This one. Is it a compression fracture?
Here.
No, it's not a compression fracture, because we can see retropulsion of the fracture fragment here. The posterior cortex is not intact, hence it is a burst fracture. Okay, so now we have burst fracture, compression fracture, and distraction fracture. Coming to this one. Which fracture is this?
Again appears to be osteoporotic one.
Yeah, osteoporotic one. And there are one fracture or two fractures?
Two.
Two fractures. Here also it is involved, and this vertebra is also involved.
Last.
The osteoporotic wedge compression fracture. So I think I think everyone understood the radiograph of spine very nicely, and it should be your cup of tea now whenever you see a radiograph. And I think may have been a little monotonous, but may have conveyed you the presentation and the message nicely.
Thank you, madam. It was a wonderful session, and I'm sure all the participants must have enjoyed the quiz also. Your presentation was exceptionally effective and lucrative. Pleased to inform you that our today's 29th webinar is already approved by Maharashtra Council of Indian Medicine, Mumbai. Ma'am, your comprehensive presentation has provided all the participants with deeper understanding of the complexities of spine imaging and the crucial role it plays in diagnosing and managing various spinal conditions. Your passion for teaching and your dedication to advancing medical knowledge are truly inspiring. Now, I will request our today's chairperson, Dr. Shalini Rai, madam, to convey her remarks, ma'am. Shalini, ma'am.
Thank you, Dr. Pallavi. At the outset, I would like to thank the organizers for giving me the opportunity to be a part of this wonderful lecture series and attend the today's lecture in the form of a chairperson. And I'm very thankful on behalf of the organization to Dr. Amita Thakre ma'am, who gave her wonderful lecture, also sharing her clinical insights and experiences in this lecture, because there are many books which we also refer for reading of X-rays, but the clinical expertise which a person gathers with the insights that are very crucial, because it helps us to understand in a nutshell what she has gathered over the period of years. So we are very thankful to you, ma'am, Dr. Amita, because your clinical expertise helped us all to gather and recapitulate in a very short period of time what all the clinical pearls were there regarding the cervical, lumbar, and thoracic X-rays and their clinical applications. So, ma'am, we are very thankful to you, and the lecture was immensely beneficial to all the teachers as well as the scholars. So, with these words, I would like to thank everyone, and especially the guest and the resource for today and the organizers. Thank you.
Thank you, ma'am. Your kind words. If anyone has any doubts or question, I think we can take 2 minutes. Wagner sir, we can take 2 minutes.
Yes, madam. Yes, madam. I was supposed to ask. If you are having any.
Yes, ma'am. I have already put in chat book. I've already put in chat box, ma'am. If anyone is having any questions, they can
Dear
put
madam,
there.
if you are having the pics of radiographic pics of osteoarthritic spurs with osteoarthritis X-ray or rheumatic pathologies of the vertebrae.
No, sir, I am not having right now. I think I have to prepare another lecture for that, the rheumatic arthritis or the another thing, because it's all together completely a different and very vast experience. So here I have covered the degenerative and the trauma wala part mainly. But if you want me to cover that thing, I think we have to take a different lecture.
Yes,
Some
other
now
time
we
we
are
will.
more familiar with the anatomy, how the normal vertebra looks on the X-ray. I think everyone is now comfortable with that. How the normal X-ray, normal vertebra, normal disc space will look. This is the foundation, and on which we can evaluate the radiograph of the spondyloarthropathies further.
Yes, definitely, madam.
Because if I had put in this lecture, it would have been much more.
Yeah,
so
I can understand.
If we want that to be, I think we have to take another lecture for that.
We will
We have to
conduct it
cover
on
the
some other
joint
time.
perspective also.
Yeah, definitely. Sure. So, Dr. Pallavi, can you propose a formal vote of thanks?
Yes, sir. Sir, I would also like to thank ma'am, because from this year, as the NCSM syllabus has changed and X-ray of spine is involved as a new syllabus point. So I'm sure this video is going to help all the UG students as well as the PG students. Now for the formal vote of thanks, I would, on the behalf of organizing committee, I would like to extend our sincerest gratitude to Dr. Amita Thakre madam for sharing her expertise and wealth of knowledge in today's webinar on spine disorders and radiological and imaging diagnosis. I would also extend our deepest appreciation to our chairperson, Dr. Shalini Rai ma'am, for your invaluable contribution. Your presence has enriched our experience, and we are honored to have you on our platform. I want to express our appreciation to our President Dr. Subhash Wage sir for his tireless efforts and the whole organizing team without whom this webinar would not have been possible. Your behind the scene efforts ensured a smooth and seamless event. I express my sincere thanks to Dr. Snehal Rane Madam for introducing our association to all our participants. Last but not the least, I would like to thank all our participants for their active engagement. Your curiosity and enthusiasm have contributed to making this webinar a valuable learning experience for everyone involved. Thank you for joining us.
And I thank Dr. Pallavi Chaugule, Madam, for this wonderful and excellent coordination of this session. And
Thank you,
at
sir.
this juncture, I want to express my special gratitude towards Dr. Amita Madam, who, whenever we give her a call and she comes to, she come on our platform despite having the busy schedule, and she has to go at some other place today. Despite that, the madam had given us a time, and I'm very much thankful to her. And hopefully in future also, we will call her again for enlightening us on spine pathologies. And
Definitely, sir. I am
thank
like
you,
to teach.
thank you very much, madam. It was like attending a radiology class in the UG or
Yes, sir.
PG days,
So
and
if you have to learn
and
every
it had made me
day,
wiser also, because I was, all others mics were mute, and I along with some only Pallavi were the most of the answer giver, and it had also uh, tested my acumen also, radiological acumen also. So thank you very much, madam, and I thank
everyone
everyone.
tries to
And
participate, sir, that will lead to the learning.
yeah,
The
because
जीवन
you,
का
whatever you
सुपरहिट
shared
किसी
during
को
the X-ray conference, madam, that time the audience, they have wonderfully responded to you, and it was like
yeah,
a two-way communication. And
yeah, I missed that in this webinar,
yeah,
but
because the
so
webinar has limitations, but what you
yeah,
conducted on 5th of November, it was like, I mean, I could see the peoples, they were giving the live answers, and as like a radiologist, they were interpreting the things with your lecture so much in the one lecture only. You made them so much wiser. That time I could see that.
yeah,
And
thank you.
hopefully in the or other next conferences, Shalini madam will also join us. Though I requested her to join during the November Diagnocon, but she could not. But I extend my thanks to her also for accepting our request to be chairperson for this session. She is a wonderful lady and very cooperative. Thank you very much, madam. And I
So
thank
one
everyone.
suggestion I have is that we can plan if you want to learn about the radiograph of spine, we can plan the series. Like now we have covered trauma mostly and the degenerative mostly. And next time we can take spondyloarthropathy, rheumatoid, and everything. So
Yes, yes,
that we
definitely.
will have to plan, sir. And along with
Sure,
that,
sure, ma'am.
we can take the joints also. Because I
Yeah.
think in Ayurveda, the patient, they are mainly coming from the osteoarthritis or the
Yeah.
spondyloarthritis.
Exactly. Most of the patient, they approach in Ayurvedic OPD for a Sandhivat, what they call Vat ho gaya, Sandhivat. It
So
includes
I
a
think we
wide
will have
array
to
of
take a different lecture, sir, for that.
rheumatic spondyloarthropathies. So we will definitely conduct. And I think with this lecture, our community is sufficiently sensitized. And I want to make one announcement that we are from this year, we are starting a diploma course, that is DXGT, Diploma in X-ray Diagnosis and Techniques. I request all the Nidanians to explore the possibilities if they can join this course, and it will be immensely beneficial to them. And with the guidance of madam, who is our going to teach us, I think it will be a wonderful learning process. Once again, revisiting the class and learning all the minute details of radiographic interpretation. So I request all the Nidanians to explore the possibilities for joining this course wherever they are. Thank you very much. And I declare this session is over.
Thank
Thank
you,
you, sir.
everyone.
Thank you, everyone.
Thank you, sir.
Thank you, sir. Thank you.